Welcome to the HighRisk Newborn Lecture. Before we start, there are some risk factors that are going to predispose this newborn to be a high risk. And those risk factors are prenatal and intrapartum risk factors, which are diabetes, okay, the mama that had diabetes, narcotic analgesics, narcotic anesthesia, fetal asphyxia, difficult or prolonged labor that mama had. And when I say mom, I said obviously, this newborn's mom. Multiple gestation, a preterm newborn or a post-term newborn, a newborn that now has congenital anomalies, a maternal or neonatal infection. All these are risk factors that will prone this newborn to be a high risk. If you're small for gestational age, or if you're large for gestational age, like microsomic babies. We're going to start with preterm newborn. Again, I could move my slide. That would be great. Okay. We're going to start with a preterm newborn, which is a gestational age under 37 weeks of gestation, and they're going to be less than 2,500 grams, which is about 5 pounds, 8 ounces. Preterm births can be attributed to many causes, and I just went through some of the risk factors, and of course I put some of them here: gestational hypertension, multiple pregnancies, and adolescent pregnancy, lack of prenatal care, substance abuse, smoking. And these babies do have complications. Okay, these preterm newborns do have complications. Preterm newborns are at risk for a variety of complications due to their immature organ systems. Also, due to the degree of complication, depends on gestational age. And then closer to 40 weeks, obviously, less chances for complications. The first one there on complications, you've got a list, but I want to add delayed growth and development. Then you have respiratory distress syndrome, and that's a decrease in surfactant in the alveoli, regardless of birth weight. And the next one on there is aspiration. And remember that the premature infant doesn't have an intact reflex. So they have an inability to effectively suck or swallow. Then there's apnea of prematurity because of their immature neurological system. Then they have another complication called intraverticular hemorrhage, IVH. And that's when they bleed in or around the ventricles of the brain. Another complication is retinopathy of prematurity. That is associated with hyperoxemia. We give them oxygen and it's wonderful, but we've got to be careful because they can get prone to a complication called retinopathy of prematurity, and that is associated with hyperoxemia that results in eye injury and blindness in premature infants. This is why when they're in the NICU, they will get eyeballs checked. They'll get their hearing, eyeballs checked before they are discharged. And if they have a longer course in the NICU, they will get it checked throughout. Then there's a PDA, and some of these, like the PDA with the cardiac, you will have a whole lecture on anomalies. You will have a whole lecture on PDAs in Block 4. But because we are doing this assessment for the first time, you as the nurse in the labor room, the transition RN, you will be the first ones to see this. Okay, and the PDA is when the fetal ductus arteriosus fails to close right after birth. And there's another term very famous in the NICU, in the neonatal ICU, which is the NICU, called necrotizing enterocolitis, NEC, N-E-C. Okay, necrotizing enterocolitis. This is acute inflammatory bowel disorder that occurs primarily in preterm or decreased birth weight neonates. It is characterized by ischemia, which is necrosis, which is death of the GI mucosa, which may lead to perforation and peritonitis. And we've got neonatal sepsis, and we will cover these complications, okay, as we move into this high-risk newborn lecture. Neonatal sepsis, hypoglycemia, and also hyperbilirubinemia that a lot of you have looked up and done a teaching learning project on in OB clinical. And with hyperbilirubinemia, I know we're going to explain this further into this lecture, but there's a term called kernicterus, K-E-R-N-I-C as in cat, T-E-R-U-S, kernicterus. And this is when the Billy's levels become 12 to 15 milligrams per deciliter. That becomes the red flag. That becomes your panic level, is this kernicterus. And what is this? This is bilirubin encephalopathy. Okay, it's neurotoxicity, and that it involves a deposit of unconjugated bili in the brain cells. And this results in impaired intellectual, perceptive, motor function, and even death. So this is what we never want, is for this baby to become kernicterus, to have bilirubin encephalopathy. And that is why we do the lights, the Billy lights. So stay tuned, because we will be talking a lot more about this. Going back to symptoms of the preterm newborn. So they do have periodic breathing. Okay. They do 5 to 10 seconds, they pause, and then 10 to 15 seconds with rapid respirations. This is their periodic breathing. 5 to 10 seconds and they pause, and then they do 10 to 15 seconds and they do rapid respirations. Apnea, they pause in respirations longer than 10 to 15 seconds. Okay, so apnea is the pausing in respirations longer than 10 to 15 seconds. Then they have low birth weight. Their heads are larger in comparison to their body. Remember lanugo, the term lanugo, they're preterm, so they have lanugo over their bodies. They have minimal creases in the soles and palms of their little feet and their hands. They have a flat areola without the breast buds. Their heels are fully movable to the ears. So these little heels over here, they're so flexible, they move. Their heels are movable. You can move their little legs. They're very flexible. They're very tiny. Inability to coordinate, suck, and swallow. They have wrinkled features. Their skin is thin, smooth, shiny, and may even be translucent. Their veins are visible under their skin. They have soft, palpable ear cartilage. That's why their little ears are really soft and palpable. So make sure that they're flat. And if they move forward, make sure that you put them back and that they're nice and flat when you move them side to side. Oops. Okay. And remember that their eyes are closed if they're still 22 to 24 weeks gestation. Okay. Their eyes are going to have closed eyes if they're 22 to 24 week gestation. Nursing interventions that we do for these little ones. Okay, on initial assessment, on a very rapid initial assessment, we're obviously monitoring vital signs and we're observing for complications. And we are assessing their ability to consume or digest nutrients. And just keep in mind that before this preterm infant can be fed by breast or bottle, they must have an intact gag reflex. So they need to suck and swallow to prevent respiration, to prevent aspiration, to prevent aspiration. Okay? So we need to make sure that that gag reflex, is intact in order for them to, be feeding breast or bottle. Now, nursing interventions. We're going to perform resuscitative measures. We're going to ensure their thermoregulation, so maintaining their temperature. We're going to administer respiratory support measures, so that's surfactant via the ET tube and also oxygen. We're going to administer parental nutrition and fluids. And if they're less than 34 weeks, that's going to be IV or gavage. And the gavage is the oral gavage or nasogastric, an oral gavage. Okay, that's going to go from their nose to their tummy or from their mouths to their tummy. Okay. We're going to administer meds, okay, as prescribed. We're going to minimize stimulation and do something that we called cluster nursing care, all of it together. Provide for non-nutritive sucking, so we're going to do a pacifier, okay. When we OG feed, when we do the oral gavage, we're going to provide a pacifier, okay. Keep parents informed and educate about their care of this preterm infant, okay. And we're going to position them prone, okay, side lying, prone. We're going to use blanket rolls. We're going to use swaddling, and we're going to secure their holding because that's how they're used to being in utero. Okay, a nice, tight, secure, structured environment. Okay, so you're going to see that we use, blanket rolls and swaddling and a lot of that secure holding. What is the goal? Our goal here with the newborn in their care, this preterm newborn in their care, is meeting the infant's goals and development needs and anticipating and managing associated complications such as respiratory distress syndrome, RDS, and sepsis. And our main priority is supporting their cardiac and the respiratory system. There is a list of what we do for medical management. We'll get a urinalysis, they'll get a specific gravity, we'll do chest x-rays on them, arterial blood gases, head ultrasound to see if they've got the intraverticular bleeds, okay, the IVH, the intraverticular hemorrhaging. We'll do echoes to see what their heart, if they have those little PDAs in their heart. We'll do eye exams. We'll do serum glucose, calciums, and bilirubin. And of course, again, in the NICU, what are our goals? Once they're in the NICU, well, our goals, they're going to receive meticulous care. We're going to do observations on them until they can receive oral feedings, maintain their body temperature, and they're going to weigh at least 4.4 pounds. Usually they will be in the NICU until they've reached mom's expected date of delivery, okay, or mom's expected date of confinement, her EDC. So if they were born at 24 weeks, then we tell the parents, we tell the mom that we tell the family members, that are there, the family, that this baby, plan for this baby to go home, sometimes with many challenges, by the time that this baby's would have been 40 weeks. Sometimes they do earlier. Okay, they go home earlier. So sometimes you'll see them early as 5 pounds and they go home. And of course, lots of discharge planning. Okay, so home care needs of the infant's parents are assessed. Information is provided about the infant's care. Referrals for appropriate resources are given. Referrals for home health assistance. And some key points. Preterm infants are at risk for problems stemming from their immaturity. You already know that. Nurses who work with preterms and other high-risk infants observe them for respiratory distress and other early symptoms of physiologic disorders. Adaptation of parents to preterm or high-risk infants differ from that of parents to normal terms. A lot more challenges. Nurses can facilitate the development of a positive parent-child relationship. Nurses' skills in interpreting data, making decisions, initiating therapy in newborn intensive care units are crucial to ensuring this infant survival. And before discharge, as I was saying before, parents need special instruction before they can take home a high-risk infant. So whether it's the mom, whether it's mom and significant other, whether it's mom and maybe a grandma, they are going to be able to be checked off on CPR, oxygen therapy, suctioning, okay? So they do need special instruction and developmental care. Brings us to our next challenge, and that is hypothermia. Okay, hypothermia is increased consumption of calories, and of course that equals a loss of weight. They use fat for energy, so there's a lack of surfactant, so then there's respiratory distress syndrome. And they use increased glucose consumption, and then that equals your hypoglycemia. Management of hypothermic babies, high-risk newborns, okay? You need to make sure that you dry the infant immediately after birth and while you're bathing them, after you bathe them. You're reducing or eliminating heat loss through drafts and contact with cold objects. So always, always wrap your babies. Okay, when you weigh your babies, you want to put the paper or the blanket on the scale. You want to postpone their initial bath until that temperature has stabilized. And again, you want to keep their axillary temp between 97.6, so closer to 98 always, 97.6 and 99. Management, if of course their axillary temp is 97.6 or less, okay, so your cold babies, you want to put the hat on the infant's head, you want to wrap them with warm blankets, you want to assess the oxygen status and hypoglycemic status, and you want to rewarm the infant slowly, okay, slowly. So hypothermia, just on a note here on a little red flag, hypothermia is an early sign of sepsis. So if these babies are having a challenge keeping their temp, you need to have a red flag out and see if they're not septic, okay, or they're getting septic. So hypothermia is an early sign of sepsis. Another high-risk newborn challenge is hypoglycemia. Blood glucose less than 40 milligrams per deciliter in a preterm or infant term baby. Now, you usually will see nursery policy for hypoglycemic infants, and that's usually a dextrose PRN. If the blood glucose is less than 40 milligrams per deciliter, and if that's the case, then you're going to give them D5-WPO. Okay. Definition of normal glycemia is 50 to 100 milligrams per deciliter in infants. Who are the newborns at risk for hypoglycemia? And I know you've heard this before when we talked about the L&D lecture. Infants of diabetic moms, small for gestational age, your preemies, your newborns experiencing cold stress, and your delayed feedings. Remember, stress, for the newborn could be that when we talked about it, the newborns that are prone to hypoglycemia are those newborns that in utero right before delivery or during mama laboring, they had perinatal asphyxia. They were intrauterine growth restriction babies. Okay. You also have to be careful. We said that once that umbilical cord is cut, okay, neonatal hypoglycemia occurs because now it's caused by the interruption of the glucose supply with the cutting of the umbilical cord. So if you suspect at any time that your newborn might be hypoglycemic, you've got to make sure that you do a glucose check on them. Okay? Signs and symptoms of hypoglycemia. We've got tremors, jitteriness, lethargy, decreased muscle tone. They could have a floppy, posture. They could be what we call poor feeders. Okay, they're just having a hard time with the suck, swallow, and breathing, and all of that coordination. They could be apneic. They could be anorexic. They can have a weak cry, and your worst case scenario, obviously, we never want to get to, are seizures. So, how is it diagnosed? With a dextro stick. Okay, and always hypoglycemia is going to be worse by the presence of hypothermia or a respiratory distress syndrome. Okay, so you want to make sure that you're, monitoring their blood glucose levels closely. Okay, you want to monitor it with, IV. If they're unable to PO feed, then you got to do a D5W IV. Okay. That has dextrose water in it. You want to monitor them for signs of hypoglycemia. You want to do their vital signs. You want to do their temperature. Okay. And then management, check blood glucose within 30 minutes to an hour after they're born with insulin-dependent diabetic moms. Okay. We want to breastfeed immediately because that is how we manage hypoglycemics. That is why we want to make sure that when their babies are born, depending on, mom's labor and delivery and her history, want to make sure that she starts to breastfeed because we always, once you cut that cord, baby's doing everything on its own, and we want to make sure that they're not lowering their blood glucose levels. So either you breastfeed immediately or you do D5W or D10W PO or IV. Again, you don't want to feed an infant who is lethargic or at risk for aspiration. And if you've already started the treatment for hypoglycemia, then recheck the blood glucose before your next feeding. I will tell you that in-house, if you have to do a treatment for hypoglycemia, and let's say you fed in an hour, you want to go ahead and test them just to make sure that it has worked. Okay? And that leads us into, of course, the big macrosomic baby with your little babies. Big, juicy macrosomic baby. That leads us into neonatal sepsis. So definition, generalized infection that has spread through the bloodstream. And a little bit of patho on neonatal sepsis is that they've got immature immune system. They have the inability of the body to localize the infection. And they also lack immunoglobulins. Okay, and that protects them against bacteria that does not cross the placenta. Usually neonatal sepsis will manifest itself within 24 hours after birth. And it does, carry a mortality rate of 10 to 25%. So that's why assessment on these babies. Causes, prolonged rupture of membranes, difficult labor, resuscitation, invasive procedures. Especially we've got to do Foley's on mom that may be an ET tube, maternal infection, maybe mom had a UTI. If she's had beta hemolytic strep, which causes meningitis and sepsis, then we should do cervical cultures on this mama. That's why we do cervical cultures on this mom prior to delivery, and we give them antibiotics because the beta hemolytic strep infections do cause neonatal sepsis. Okay, so this is why, if that's the case, we will give antibiotics to baby as well when they're born. Aspiration of amniotic fluid, formula, mucus, and then your nosocomial infections that they might acquire in the hospital that may cause them to now be septic. Other causes of neonatal sepsis could be any of those torch infections, symptoms, temperature, obviously they're cold, temperature instability, feeding intolerance, okay? They have a weak suck, okay, and intake. They have behavioral changes, can even have decrease in O2 sats. They could be jaundice, okay, behavior, Jaundice, lethargic, pale, or your worst case scenario, seizures, respiratory distress. So they've got some sternal retractions, they've got grunting, they've got nasal flaring, and hyperbilirubinemia. Initially, they can be tachy. Excuse me, they can be apneic, and then they can be brady. Then they go bradycardic. Sometimes symptoms, it could be that there's a suspicious drainage, maybe in the eyes, in their umbilical cord stump. They could be vomiting, there's diarrhea. Sometimes it could be a little bit of abdominal distension, and that's large residual. If you're feeding by gavage, you'll have a large residual. Now, how do we manage? Obviously, we're going to obtain cultures. Okay, we're going to obtain a complete septic workup. And that's blood, CBC, urine, CSF before starting antibiotics. Okay, you're going to administer antibiotics as ordered. And usually they're, positive for blood cultures, and usually it's polymicrobial, so more than one pathogen. Indication of infection and sepsis. Then the organisms that are usually responsible for neonatal infections are staph, E. coli, Haemophilus influenza, Group B strep. And of course, we want to, obtain your vital signs, in physical assessment and observe for any changes. Okay. And then, of course, we can't forget, because they're septic, we can't forget to do a chem profile. Okay, usually in the chem profile is going to show some fluid and electrolyte imbalance. Some key points: regardless of the infant's disorder or condition, healthcare providers must remember that infants belong to a family that also has many needs. So infection in neonate may be acquired through in utero, during birth, during the resuscitation process, or from within the nursery. That leads us into another high-risk newborn challenge, which is hyperbilirubinemia. Okay, the term refers to excessive bilirubin in the blood characterized by jaundice. So newborns have more red blood cells than adults, so there's more breakdown at any given time. The normal for red blood cell to break down is a bili is formed, but does not cause the jaundice. Remember that liver metabolizes it and gets rid of it in the gut. Okay, and they become jaundiced because the liver enzyme, which metabolizes bilirubin, is immature. Okay, now bilirubin gives the yellow color to the urine and the brown color to the stool. So just an interesting fact, okay, is that bilirubin gives a yellow color to the urine and a brown color to the stool. Now, some lab values before going to the different types. Normal labs, birth to 24, 0 to 6, then day 1 and day 2 usually goes up. If they're truly hyperbilirubinemic, it's going to continue to go up, and usually by day 7, they decrease to below 2, and that is your norm, okay? Your norm, because 50 to 80% of all newborns are visibly jaundiced during the first 3 days of life. This is usually the norm. That's why your normal is that in day 1 and 2 it's 8, and then your third day it goes up. We'll put them on some lights, and then by day 7 they're decreased. Okay, if they have those total bili levels between 13 and 15, which is panic, which is your red flag of hyperbilirubinemia, then of course they're going to be on lights. Okay, the different 2 types is unconjugated, which is fat soluble, which is your physiologic jaundice. This is the one that's most commonly seen in newborns, and this is the one that happens after, okay, usually begins after 24 hours of life. Okay, this is where that sentence that I just told you, 50 to 80% of all newborns are visibly jaundiced during the first 3 days of life. This is that unconjugated, that fat soluble indirect physiologic jaundice, commonly seen in newborns. And this is a lot of times because of sepsis or dehydrated and all this bruising, large amount of bruising, from delivery. Okay. The one that's not good is conjugated. Okay, the conjugated is water soluble. It's pathologic jaundice. That this suggests hepatic problems, like, for example, biliary atresia, a tumor, damaged liver cells, hepatitis. This is the jaundice that usually begins within the first 24 hours of life. And if mom goes to prenatal care and they've done her ultrasounds, you are suspecting that this baby has some kind of liver challenge, okay? Born with some kind of liver challenge, some damaged liver cells. These babies that are pathologic jaundice, that have, the pathologic jaundice, that have this hyperbilirubinemia begins usually within the 24 hours of life, usually born with jaundice, and that's not this is not the norm. Have a characteristic also of brown colored urine. Okay, brown colored urine. And then again, unconjugated bili levels in the blood, that become carnivorous, and then they get higher and higher. Remember, their panic levels are this 13 to 15. Okay, and they can become hypoxic, they can become asphyxia, they can, be hypothermic. That's why bili levels are so important, and we monitor them. They're so important. Just a picture of another Adam healthy baby and a baby with severe jaundice, and then management, okay, or phototherapy management with these babies, and our exchange transfusion with these babies. So management with phototherapy, okay, we'll take that first. So phototherapy management, and these are abiding by the guidelines of the American Academy of Pediatrics, okay, so you will see that when they start to have levels of 9, 10, sometimes even 8, they're going to start doing their phototherapy management. Okay, so they go under lights. Here's a picture of them going under lights with just the diaper. Okay, and of course their goggles. Okay, and what are we going to do? We're going to cover their infant's eyes. We're going to remove the covers every 2 to 3 hours. We're going to change the position every 2 to 4 hours and assess their skin, assess their stools. Okay, because green stools are indicative of bilirubin being excreted through the stool, which is what you want. Increase fluid intake to prevent dehydration. You want to assess their temps every 2 to 4 hours because of hypothermia. And you want to monitor their bili levels as prescribed. Okay. Then we're going to go to another management. So if their levels continue to increase, okay, we're going to do something called an exchange transfusion. Okay. And that is used to treat infants who increased levels of bili cannot be controlled by phototherapy. And usually the cutout, that cutoff point is usually about 20 milligrams per deciliter. So you're watching them and you're going to do an exchange transfusion sooner than later. Okay. And it's the replacement, kind of like dialysis, the replacement of 75 to 85% of circulating blood by withdrawal of the recipient's blood and injection of a donor's blood in equal amounts. That leads us into respiratory distress syndrome. Okay. Causes and risks, preterm infants. Okay. Again, meconium aspiration. They could be term or they could be post-term. And then there's a term called transient tachypnea of the newborn, and that's caused from delayed absorption of fluid in the lungs from delivery. Okay. And, they could breathe. What happens is they are breathing fast, or they have labored breathing. They don't use the lungs to breathe. All the O2 is coming from the placenta. So in utero, the lungs are filled with fluid, and as the baby's due date nears, the lungs begin to absorb the fluid. And then what happens is this TTN. So after delivery, as a newborn takes the first breath, the lungs fill with air. And then any remaining fluid is then coughed out or slowly absorbed through the bloodstream or the lymphatic system. And that's the norm of how they're breathing right after they're born. In TTN, the extra fluid stays in the lungs, and it's harder for them to breathe in the oxygen properly. Okay? This usually, that's why they have this transient tachypnea of the newborn, caused from the delayed absorption of fluid in the lungs from delivery. We gotta watch out. So RDS and symptoms of RDS are again grunting, cyanosis, tachypnea, more than 60 respies per minute, nasal flaring, your respiratory acidosis. Okay, RDS, this is a lung disorder that usually affects the preterm infants because, again, of a lack of pulmonary surfactant. Okay, and what is surfactant again? It's a phospholipid that assists in alveoli expansion. So it keeps the alveoli from collapsing and allows gas exchange to occur. So that was just a little, remember what surfactant is. This is, we're talking about preterm infants. We're talking about, causes of, respiratory distress. So just a reminder. And then, of course, your symptoms, your grunting, your cyanosis, your nasal flaring, respiratory acidosis, your retractions. These babies, symptoms they look like. And then what do we do to manage? Well, we increase oxygen consumption. We administer warm humidified oxygen. We try to keep the SATs as close to 90% as possible. Okay, as close to 90%. Hold feeds of the respiratory rate is more than 50. Okay. Because of they're prone to aspiration. Suction frequently, KPRN. Suction is needed, suction frequently if you need to. Monitor oxygen, SATs, and blood gases, ABH. Okay. Another challenge, a newborn of the addicted mom. Okay. Some of you did look this up as well for your teaching learning project, so this is a good thing. So a lot of you have heard this, again. Symptoms. Well, you can have withdrawal symptoms that can occur as early as 12 to 24 hours after birth, okay, with the withdrawal. And then still the treatment and the medications primarily focus on opiate and even cocaine withdrawals, okay? And that's why we talk about withdrawals, because a lot of studies are showing that combined use of opiate therapy and phenobarb reduce the overall length of hospital stay and duration of these symptoms. And still, a positive drug screen in a newborn of a mom without a prescription for that suspected drug does warrant an investigation by the state's child protection agency. Okay. And I've got many studies, but you're going to see in the hospital settings opiate treatment for opiate withdrawal in newborn infants, and morphine is what you are going to be exposed to, what you're going to see. Okay, the morphine to withdraw symptoms, morphine, and sometimes they'll use methadone. Okay, opiates. So you're going to see this, and that is, opiates such as morphine is the initial treatment of choice, okay, for opiate withdrawal in newborn infants. So lots of great articles are out there, and that just goes evidence-based together with the treatment that they're doing in the hospital for these newborns. Signs and symptoms, high-pitched cry. They're very irritable. They're very difficult to console. Decreased sleep pattern, hyperreflexia. They're tachypnic, vomiting, diarrhea, uncoordinated sucking reflex. Management, and we pretty much manage the newborn of the addicted mom the same as that alcohol-related birth defect patient. Okay, we assess respiratory rate, the weight, the reflexes, their central nervous system, position infant on the side to facilitate the draining because we don't want them vomiting and aspirating. We suction them PRN, decrease stimuli, swaddle for comfort, and that's what we do at the hospital. We swaddle them, and we put them in the. I think I did say this in. We had a case study in Skills Day, so I think we did say this where we swaddle them for comfort, and we put them on these your little the beds that have like the little machine that will either do a little music, has a little bit of stimulation, has a little bit of vibrating motion, and then you put them on these little bassinets that do that. We have other ones that look like a radiant warmer without the heat on the top, and then they kind of have this little, again, this swinging motion, just so that they have that, and they're swaddled for comfort. We do obtain their meconium and their urine for drug screening. Usually that happens in the first or second day. We monitor eyes and nose, their weight. Again, we administer the meds, the methadone, the phenobarb, your morphine, and of course we want to offer their pacifier. And we do these meds for decreasing their central nervous system irritability and also to control their seizures. Okay. And referrals, mom, to drug or alcohol treatment centers. Some key points. Nurses often are the first ones to observe the signs of newborn drug withdrawals. Remember, this is a brand new baby, and you are the one that's observing this baby, from day one, from first hour. Providing high-quality perinatal care to a varied population with multiple conditions is complicated by special needs of high-risk drug-dependent clients. Signs and symptoms of the infant withdrawal varies in the time of the onset, depending on the type and dose of that drug involved. And that's, we're moving on to alcohol-related birth defects. Perinatal alcohol exposure is a public health concern. It could be avoided if you don't drink while you're pregnant, okay? Because it is a leading cause of mental challenges, okay? Not to say mental retardation. We've tried to go away from that word and added the mental challenges. It is a health problem, okay? It used to be known as fetal alcohol syndrome. And, it is now changed to alcohol-related birth defect. And this is a great little picture here of when mom consumes the alcohol, it crosses the placenta, it enters the fetal circulation, it's metabolized in fetal tissues, and then it's detected in this newborn's meconium. Signs and symptoms, we have cranial facial anomalies, short eyelid openings, flat mid-face, flat upper lip groove, thin upper lip. They usually are microcephalic, little brains. They're hyperactivity, so they have some sleep disturbance. There's developmental delays. There's attention deficit syndrome. Again, they have a poor suck, congenital anomalies. That's why it's a birth defect. It's alcohol drinking in pregnancy equals pretty much a birth defect. Okay, you're going to see your cleft lip and palates. You're going to see congenital heart defects. Is usually what you see in the signs and symptoms. Management, we manage the alcohol-related birth defect babies just like we do with the drug with the newborns of the addicted mom. Okay. And again, referral them to, moms to alcohol treatment center, and we manage them the same. Okay. We assess the respiratory weight, their reflexes, elevating the head when feeding, suctioning them, swaddling them, obtaining their meconium and urine, monitoring their eyes and nose, administering their meds, phenobarb, of course, for seizures, offering their pacifiers for non-nutritive sucking, and referral, okay, moms to alcohol treatment centers. And this is, kind of that, thin lip, space in between their eyes. And this is when they're a little older. Again, another great picture. And then we've had metabolic disorders. And these are your inborn errors of metabolism. I want to share my screen after we go through the slides so that you can have it on this recording and you can go back to the Arizona Parent Guide to Newborn Screenings that I want for all of you to take a look at. Okay. Before we go into the metabolic screening, one more thing I want to say about the alcohol related birth defect is that you have to remember that alcohol does cross a placenta. There's an increased risk of congenital anomalies, mental deficiency, intrauterine growth restriction. Okay. Which, that being said, with the congenital anomalies, goes along with a big risk for congenital heart defects. Okay. I might have mentioned it, but I wanted to mention it again. I don't want to leave that out. Okay. And now we go into our metabolic disorders. Key points on metabolic disorders. The reason why we go through PKU and we go through galactosemia and we go through hypothyroidism, it's because these were the first three that were out, that each state required. Okay. So some stats, by 2008, all 50 states required newborn screening for at least 21 disorders. And we go through PKU and galactosemia and hypothyroidism is because the first test was PKU. Okay. And the second test that ever, was screened for was hypothyroidism. Okay. And now 29 conditions. And they're working on future, very soon in the near future, for newborn screening up to like maybe 100. So instead of all the states, mandating, 29 conditions in this newborn screening, they're going to be able to test for, a whole lot more, for at least 100. Better prognosis for these newborns, futures. So with that being said, and a little bit of stats, giving you a little bit of statistics, it is the most widespread use of postnatal testing for genetic disease is routine screening for newborns for inborn errors of metabolism. Okay. And this is, according to obviously the Center for Disease Control and Prevention. Each state runs its own newborn program. All the states, and that's why we have it on these slides, because all the states are going to screen for PKU, hypothyroidism, and galactosemia. So that's why these are the three that are identified here, because no matter which state, all states screen for these three. Okay. It's curative and rehab problems of an infant with a congenital disorder are often complex and require a multidisciplinary approach to care. Then a little bit here on newborn screen. When I clicked on this, I wanted to show you the guidelines. It didn't do it for me, so I'm going to share the screen and give you the Arizona Parent Guide to Newborn Screen, and then you can also look up newborn screening program guidelines as well. In the most successful lab-based prevention program, it is the most successful lab-based prevention program in public health. Early detection, diagnosis, intervention can prevent death or disability and enable a child to reach their full potential. Okay. Newborn screening identifies the conditions that can affect a child's long-term health or survival. Okay. And then we go through these three, and then in a minute, I'm going to share the screen. That way you have it and you can look at it for the Arizona Parent Guide to Newborn Screening. And then it will go through all of the disorders that this screening tests for. Okay. So you can see how very important it is. And it's going to even be, better when they do more of the screenings. Okay. So PKU is a disorder that affects the body's protein utilization caused by abnormal metabolism of the amino, thinking about OB and labor, amino acid phenylalanine. Okay. If the disease is not detected early, the infant can lose 10 points in IQ in the first month of life, and it can lead to, and I wrote mental retardation, that's how your book is quoting it. We always say mental challenge, but I wrote it just like the book. Okay, and just like still PKU is described if it's not being taken care of. Okay, that's how important metabolic disorders and this newborn screen is. Assessment, we obtain the PKU. All the newborn, because they're inborn errors of metabolism, you have to wait at least a minimum of 24 hours after we fed them to show adequate protein levels. Okay, so that's why we obtain PKU right before discharge. Okay, after 48 hours of birth, no later than 7 days. Okay, you have early. And infants need to be at least 24 hours of feeding to show adequate protein levels, whether it's breast milk or whether it's bottle. Okay, got the normal level supposed to be less than 2. If they're more than 4, they repeat it. Signs and symptoms: failure to thrive, vomiting, irritability, urine with musty odor, seizures, eczema. So we want to make sure that we are testing newborn screening so we can prevent. Okay. I have some stats. Usually affects 1 in 10,000 babies. And this, will identify the infants at risk. Inborn errors of metabolism are caused by an autosomal recessive trait. And of course, the management is protein restricted diet. Okay, free from phenylalanine. Okay, it's a formula modified protein and limited phenylalanine or free from phenylalanine, okay, from that PKU. And then, of course, galactosemia is a maple syrup disease. So the definition is a disorder of carbohydrate metabolism characterized by abnormal amounts of galactose in the blood. Okay, so assessment: lethargy, hypotonia, diarrhea, vomiting, cataracts, brain damage. I mean, the infant might die after 3 days if the treatment is not started. This is why we do this early and we get the results, and then that way we can repeat it and then diagnose and tell the parents, tell the mom, so that this is being taken care of. Okay, and then of course the management is a diet free of galactose. Okay, and there's milk substitutes like Nutramigen that's out there, powdered milk, that these babies can have. And of course, they'll do the Bueller test to detect the disease. But early intervention is the key. And then hypothyroidism is a problem where the thyroid gland does not produce enough thyroid hormone to meet metabolic needs. Okay. We obtain T4 levels at 2nd day to 6th day after birth from a heel stick. And then, of course, we measure height, the weight, the head circumference, and developmental milestones. And the signs and symptoms is lethargy, okay, that will give it away, and a hoarse cry and a large tongue. Okay, sometimes that's the red flag. They're hypotonic, they're puffy, they're pale skin, abdomens are distended, prolonged jaundice, constipation, feeding problems, cold to touch, they have excessive sleepiness. All these are red flags to test, for hypothyroidism, again, if that's the case. And then, of course, they have to be on thyroid replacement therapy for life. And we also monitor blood levels of thyroxine. Now, I am going to stop sharing, pause, and then bring the Arizona Parent Guide to Newborn Screening because I want to show you. So I'm going to pause this and I'm going to stop sharing. Okay, and now we are still recording. And now on your screen, you see the Arizona Parent Guide to Newborn Screen. I'm going to open up the screen so that you can see it as I am sharing. Okay, you could see this. Okay, and I'm going to move my cursor because I want you to see this. Newborn screenings, all babies are tested. Okay, tested for. Currently, we're screening for 31 core, including hearing loss and critical congenital heart defects. When the screenings are done, when the blood tests are done, when the blood tests are reported, what happens, when the screening is important, and all the tests that we're screening for. Okay, endocrine disorders, so you've got it here, amino acids, the fatty acids, the organic acids. Okay, very important exam so that you know what this newborn screening is and why is it so important. Okay, and then here is the only difference is that it's in Spanish. Okay, but we are going to know this in English, so I have it there for you. That's why I've shared the screen, because I want you to have it here. Okay, and this concludes the HighRisk Newborn Lecture. Thank you very much for listening.